What happens to people that go through their lives living on speed? It's generally not pretty, especially this disease. So one important way to accommodate to this disease, which really all of you do, it's almost a requirement for life. You do it whether you want to or not. It'll put you in bed because that's the only way you can survive. You get up and push, and then you end up in bed because your body said, that's it, I've had enough of this. Having sustained a deficit, if you get down, then there can be healing that occurs in the aftermath. It's not the injury is not necessarily permanent. In fact, it usually isn't. Cardiac output. It's important to note that cardiac output alone in liters per minute does not by itself determine adequate microcirculation. Also important is the ability to match supply-demand, as I mentioned, and factors which affect local microcirculation. Coming over in the car today, Carol and I were talking, and I emphasized to her at the time, and I do so here, is that what we're really talking about is what does the cell see in terms of output. Well, it depends on the pumping action of the heart, to be sure, but also depends on factors at the microcirculatory level itself. And those factors are endothelial permeability, dictated by VEGF, which is elevated in CFS patients. That makes the capillary more permeable to make up for the fact that there's less blood going through it. Osmolality, vasopressin hormone. Most CFS patients have an exigent diabetes insipidus, which is a compensatory mechanism to maintain osmolality in the face of increased permeability. Vasodilation, eNOS or NO. Vasoconstriction, angiotensin II. There's been studies that suggest that angiotensin-converting enzyme is elevated in this disease, which indeed it is, which is important to maintain blood pressure in the setting of low cardiac output and maintain microcirculation. Epinephrine and norepinephrine, here's your speed right here. Immune mediators, cytokines and histamine affect microcirculation. And very importantly are coagulation factors, especially fibrin monomers. In the immune system of some of our patients, which is activated, they're generating excessive amounts of fibrin monomers, which gum up the microcirculation. So it's bad enough you have low cardiac output. How much worse is it if you're gumming up of the microcirculation with fibrin monomers? So the studies done on coagulation, immune-stimulated acquired coagulopathy suggest that a lot of our patients, especially those with a family history of stroke or heart attack in early ages, who probably may be at genetic risk for this, ought to pay attention to this issue. Point is, you could have, again, a cardiac output of say 5, not too bad, right? But what if you're generating fibrin monomers on the basis of your immune activation state, punching up or plugging up the works? Then it's as if you had a cardiac output of 1, yet you're at 5. So the point is that this is a cardiovascular problem, not just a cardiac problem. By the way, how do you treat this? One of the things you use is heparin, remember? But an organic process could be nattokinase or lumbrokinase, which just chew up the fibrin. We've had significant luck with some of our patients, by the way, especially some pain patients, take the fibrinolytic agents and have less pain because they improve their, quote, microcirculation by doing so. Here's my microcirculation slide. I'm sorry for this, but the blood flow is coming down the capillary bed. The capillary is separate from the cells by simply 1 layer thick. Toxin and waste come into the blood to be removed, and the blood supplies oxygen, nutrients, hormones, and peptides. This is critical, and the white arrows are the vasodilatory phenomena, and the green arrows are the vasoconstrictive phenomena. Now you notice, this is peculiar, any physicians out there that might be present, you notice I've shown here a capillary. I didn't really know this, but some capillaries have smooth muscle interdigitated along their length. And that's what these blue balls are. They're smooth muscles. And they're in what is called the metacapillary or meta-arterioles. They're basically small capillaries leading to the true capillaries, and they form a critical function in the setting of low cardiac output, more than any other thing. This is the area, these metacapillaries, or meta-arterioles they're called. They're basically capillaries with a bundle of wrapping smooth muscle that occurs at point intervals along its length. When you have low cardiac output and the blood's rolling along here, it doesn't roll in a continuous stream. It pulses, boom, 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 like this. And the pulsing is, the movement of it is caused by contraction and dilatation, and contraction and dilatation of these interdigitating smooth muscle fibers. If you have normal output, the pulsation is once per minute. That's how it's fun. And if you have low blood flow, they're pumping at 10 per minute. Sort of like this, sort of like milking the cow. If you don't have a lot of milk, you have to milk faster. If you have a lot of milk, you just have to milk once and it all pours out, and then once and it all pours. I guess I'm not a cow man, but this is a device that the body uses to move the blood along when there isn't any. So when there isn't any, this thing has to pulse at 10 times a minute. And that takes a lot of speed. So not only is speed, adrenaline, vasomotor tone critical for microcirculation, but the lower your cardiac output pumps, there's an exponential need for more of it. In other words, you have a super need for it. The only thing you now have to be worried about is pain, because if you have pain on top of this, it depresses the vasomotor center, and these things go from cycling at 10 a minute down to 1, and your microcirculation really is knocked out. So there's a big story in this microcirculatory area, far bigger than it appears, but the underlying issue is output, A, and the need to compensate for it, and B, what is the problem of output is energy. There's not enough energy at the cell level, which will produce a peculiar type of cardiac problem called diastolic dysfunction. And then if this gets involved directly from that output loss or in compensation for the output loss, then you can have effectively starvation of the cells, which become hypoxic. And if they become hypoxic enough, they will initiate the ischemic reperfusion syndrome, which has its biggest effect on damage of the brain. Cardiomyopathy and CFS. The heart pumps blood. There's microcirculation here. Pumps blood to the heart, lung, brain, kidney, liver, gut, muscle, joint, and skin. The end arteriole is important to maintain pressure with low output, but microcirculation is rather conformed to these metacapillaries as they pulse with low output. To pulse them, they have to consecutively constrict and vasodilate, constrict and vasodilate, constrict and vasodilate to move the blood along. Constriction is necessary like a garden hose. If you had a garden hose hooked to the house, you turned it on to 7 liters a minute, that'd be enough water from the house to water the garden without a nozzle. You know, I can sit there and reach the tomato plants out in the 4th row. But if somebody comes behind you and cuts down the spigot down to, they call it spigot in Texas, I have no idea. Faucet. In England, they call it a tap. Spigot from where I come from. Anyway, if you cut the spigot down so there's only 3 liters a minute in the garden hose, this is a little dribble of water comes out because it's not enough to back pressure the line, so there's loss of pressure and it just pours out and you can't reach the tomato plant. So what do you do with your thumb? You put it over the end, so you pressurize the line to squirt the 3 liters a minute to reach the tomato plants. Just take longer, but you can do it. So your thumb gets tired, so you put a nozzle on, nozzle it down, and just adjust the nozzle. So for any given cardiac output, the nozzle, if adjusted properly, gives decent watering power. That's how your body works. So as the output goes down, you have to nozzle down to keep the pressure up, basically. You have to pressurize the line. But you still have low, you're pressurized, but you still have low cardiac output. That's accommodated by that pulsatile metacapillary. Vasodilating, vasoconstricting. Primary vasodilator is nitric oxide. Primary constrictor is norepinephrine and epinephrine. Also important in this is angiotensin II. What kind of cardiomyopathy? It's a diastolic cardiomyopathy. Echocardiography, normal. E-wave filling is smaller than the A-wave atrial contraction in filling the left ventricle. E-to-A ratio 1.3. Type 1 defect, which is the only type we've ever seen in this disease.